my name is Eugenia. Thank you for joining me today. So today I'm going to share with you some tips about how to make your shift report easier, well organized, and how to keep patients' information organized and available to you at any time that you might need it. So this is just going to be a couple examples of ICU Brain sheets, but they work for other units as well. Those help me tremendously as a brand new ICU nurse, and I'll show you why. So if it's something that's interesting to you, please keep watching. So shift report is something you do when you come onto the shift and when you're about to leave. In the beginning of the shift, you will use this brain sheet to write down everything that nurse is telling you, the information she or he has about the patient and what all happened prior to your arrival. And then in the end of the shift, you'll use this form to give a report, right? Plus adding on what all happened during your shift. When I started, I looked at all kinds of brain sheets. There's plenty online that are available. You can make your own. Some nurses just draw a grid of their own choice and use that, or they can divide one page per 2 patients and stuff like that. But when I started, one of the units had this brain sheet, and I'm not the author of this form, but it really helped me and I got used to it, and then I kind of simplified it for my own use, but this is the original, and I wanted to show you can have all that information structurized for you to find it easily and quickly when you need it. I also use this brain when giving ICU report to the multidisciplinary team. So when they do rounds, it's very easy to just go system by system, and I would have my questions or notes written on the back of the page if I had any that I wanted to remember. If any of the doctors rounded separately and needed very specific information, like let's say cardiologist comes by and you want to see the cardio information, right? And then, or remember quickly like some of their history and stuff. Then you already know where to look for it, and it's very easy to find, so you can pick and choose depending on the specialty that comes by. So what I would do, I would have copies of this sheet available. So I would have it in my backpack or purse or whatever, and I would pull out 2, which in ICU, you usually have 2 to 3 patients depending on the day. So I would put either patient sticker, which eventually I just went away with that because I didn't want to forget to have this folded in my pocket with patient's private information or anything like that. So I just put their name or their preferred name. And when you usually go to the Pyxis to draw mats, you want to have patient's initials or last name. Sometimes it's hard to keep up with all the names. So I would just put like first 3 of the last name and first 3 of the first name. That way, if I needed to look up patient and I'll pull them up in Pyxis, it would be easier for me and I don't have to worry about forgetting it. Then up on top, right next to the sticker, I write doctors' names who are taking care of the patient. So next, as you see, admission date, I would put the date that helps me understand how long patient's been in the hospital. DX, which is diagnosis. This part usually takes a lot longer, especially if they're in ICU. There are a lot of diagnoses for some patients, but I prefer to just keep it to the point, just write down the main things. And then wish list, I didn't really use. Sometimes I would put patients' allergies there, or like next of kin information, or if they had any special preferences. If they have any religious preference, you can put that down there. Next, going back to reason for ICU level of care and that part that says plan for the next 24 hours and also plan long term. This whole section I actually use for past medical history. Eventually, I modified this sheet for my own liking. I just erased these 3, and I would write patient's past medical history in there, surgical history, medical history. That's the area where I would write that. Code status, decision maker. Again, I would put in this area if they have full code or if they're DNR, and also age and sex, anything like patient specific that's not really medical related, but it's more like their status or the weight or something like that, or the height, for just details about the patient. So let's keep going. Right up top, you see 6 boxes that are responsible for 6 systems of organs, right? So neuro and musculoskeletal, as you can see here, it's written orientation. So you would put AO times 3 or 2, and I would write, like, if they don't know the date, I would put except for date. You would put their pain level, pupils, like Perla or like other equal and reactive to light, sedation with the goal of the RASS score. Are we doing awakening trials? Are we trying to wake them up every morning to do SBTs and we're stopping the sedation, or is there an order not to do that? Restraints I put next to skin because it helps me kind of think in a way that I'm checking to make sure there's no skin breakdown. And also, if we're doing neuro checks, if patient has neurodiagnosis like a stroke or any kind of a trauma or tumor in the brain, sometimes we're required to do hourly neuro checks. So that's where I would put, should we do the hourly neuro checks if we need to stop the sedation every hour and try to get a response? And what is a patient able to do? If patients have any deficiencies on one of their sides of the body, that's where I would put, like, left side is weaker than the right. Sometimes I would draw a little cross here. 2 top parts would be for left and right arm, and then the bottom would be left and right leg. And I would put weak, strong, paralyzed, paraplegic, or whatever. So you can also write the neuro, like the abilities in that part, and that helps to remember also when you chart and when you try to get them out of the bed or whatever. It helps you remember what all they're able to do. Fall risk. This is one of the things I do recommend asking during the shift report, because that's not something that you probably can find in the chart unless it's very specific. So ask the nurse that's about to leave, was the patient able to get up? Are they allowed to get up? How did they do? Are they 2-person assist? Are they 1-person assist? Are they fully independent? So that helps you, because you get report, the nurse leaves, and 5 minutes after that, patient wants to get up out of bed, and you're not sure if they can even stand. Sometimes you can't even tell what their ability is going to be like, especially after some sort of neuro event. So if you get a chance and if you remember, try to always ask, what is patient able to do? Next would be pulmonary. This is where you write everything that has to do with the breathing, with the ventilator settings, what's their O2 level, if they on ventilator, what their mode and vent settings are, breath sounds, if they have crackles or if they have diminished breath sounds and stuff like that. Intubation date matters, as well as the size of the ET tube. So that you need to know. And also the weaning trials, SBT, right? Spontaneous breathing trials. You want to know if trying to wake patient up or not. And airway and secretion. They have trach. You want to know what size and type the trach is in case it does come loose and shoots out. You cannot put that one dirty one back in. Since it's sterile, right, we have to have a spare one at the bedside, so that's why it's important to know. And also, if patient was extubated, you want to know the date when they took it out. If it was just recently, sometimes they're at risk for the need for reintubation again. And secretions, if they have like pseudomonas or something, thick secretions that require a lavage or frequent suctioning, that could be important to know too. Again, you don't have to have all these things already written. It's easier if it's there kind of when you're brand new. It helps you to remember what all you need to know. But later on, you can just put pulm and like write down what all relates to the pulmonary. Cardiac, obviously the rhythm, you want to know if they're in AFib or they normal sinus rhythm. Heart rate, blood pressure trends, always ask about that. What's the patient's normal? Because in the hospital, sometimes they're like 160 over 120 and you're freaking out, but they've been like this for like several days, and maybe you need to address it, or maybe medications needs to be adjusted. So just stuff like that. If patient had echo, You might want to know EF, which is ejection fraction percentage, with how good the heart can squeeze. Sometimes doctors, when they're around, want to know that. Also pulses, if there are any differences or if they're just 2+. Edema, that's where you would write that, and also some PRN meds. It also helps like to know what the blood pressure goal is and what the PRN med that like you want to use first, you want to use second, if they have that. Next is GI. What are they eating? If they're awake and alert, they're probably on like cardiac healthy diet or regular diet. If they have problems swallowing, they might be on some puree diet, right? If they have to have the swallow study, that's where you can write it down. The tolerance, the thickness, are they dealing okay with fluids or do they need it thickened? BM and bowel movements and also bowel sounds, that's where you can write it down, are they diminished or not? Any tube feeds, any TPN orders, any flushes with the tube feeds, right? And I like to usually write on the side here patient's temperature and ACU checks. Are we doing blood sugar checks every 4 hours, Q4, Q6? That way it helps you kind of know already, like, okay, this is something I'll need to do today, is do their blood sugar checks. Renal GU, again, do they have Foley catheter or not? If they have a Foley, usually you need to know reason why they have it, because there's nursing-driven protocols to remove Foley. If they don't have prostate enlargement or if it has not been put in place by urologist, then usually after a day or two it has to come out because it's a huge infection risk. Diuresis, are they making urine? Did they gain any weight in the last couple of days? That's fluid related, right? And you can look back at the edema. If they have dialysis, what are their days and how much volume did they remove last time they had at bedside dialysis, right? Do they have access there, like a fistula, and if you need to check on that? So things like that. And what's the normal output? Sometimes, the dialysis patient, they don't have any output at all, and that might be normal for them. But if you don't know that, then you will freak out. Oh, okay, my patient doesn't make any more urine. So you just want to know that. The next, skin. Again, that's where I put my restraints to make sure I chart on them and check on the skin. Pressure ulcers, do they have any wounds? Oh, and what stage those ulcers are? Do they have any surgical sites? Do they have any drains and JP drains, and what their output was for the last 24 hours or for the last shift? What color the drainage is? Is it bright red? Is it serosanguinous? What does it look like? Does it have a smell? Does it have a weird consistency? Stuff like that. Any dressing changes, instructions, and when was the last dressing change? So stuff like that. Sometimes after surgery, doctors give you very specific instructions to follow. So anything skin related, rashes, jaundice, or anything like that that you see, that you assess, that needs to be there, that you can put there. All right, so next is IV and IV accesses. That's where you would write what kind of lines they have, PIVs, peripheral, right? So I would put right side, IJ, intrajugular, right? ×2 or ×3, how many lumens they have, and the date like it was placed. I would put right forearm, 20 gauge, PIV, so that would be 20 gauge peripherally inserted. And then just all the IVs that they have. And if they're old and loose, you can DC them. And if you start new one, you can just quickly write down what all you have. So that helps keep up with that. And another advice, if they have IJs or any central lines, just to ask if they draw, if they've been flushed, if they work good. That helps you kind of prepare if you have some labs that are already pending, to know if you need to draw them, if you need to start a new line, or if you need to call phlebotomist and stuff like that. Next is drips. This is very helpful. I feel like it's a little bit bigger than I would like it to be. I usually put the name of the drip, current rate, max, because usually there's no goal. There's usually maximum that you can go up if they titratable. Like if they're about to expire, like things like fentanyl and all those strong narcotics and stuff, they have certain amount of time that they can go on before you have to replace them. Or like heparin or insulin, they have expiration dates. That would be helpful to note down, like if it's heparin, when is the next PTT check? Or if they're on insulin drip, like at what time, because you need to check glucose levels hourly, when is the next sugar check. Next, labs and infections. So T is for today, T-1 is for previous day. So at first the line you see white blood cells, hemoglobin, hematocrit, and platelets. So that's hematology. Usually you're mainly concerned about white blood cells because that tells you about ongoing infection, and also hemoglobin, because if it drops, the patient might need a blood transfusion, might be bleeding somewhere. Next, you see sodium, potassium, chloride, magnesium, phosphorus, calcium, BUN, and creatinine. So sodium is very important for neuro patients. Potassium, magnesium, and phos. Usually in ICU, they have a protocol. Some places let us nurses just replace according to the protocol. But if the patient has a history of renal failure or on dialysis, usually you do not replace it without asking doctor first, because they usually accumulate. Those numbers tend to go up. So you would also see their BUN and creatinine trending up as they are getting closer to the next dialysis session. Next is PT-INR and PTT. Usually we don't do INR in the hospital. That would be just PT, PTT if they're in heparin, or if we want to see if they have tendencies for bleeding. Next is the blood gas, pH, PCO2, PO2, and HCO3. Those are usually for patients that are vented. Respiratory therapists will do blood gas, or you can do point of care blood gas in some hospitals yourself, and that just helps you remember the last numbers, because sometimes it's really hard to remember all of them. And then of course you have blood cultures, respiratory cultures, urine cultures, antibiotics and stuff. I would usually jot down like what type of antibiotic they're on, if they have any cultures pending, or if they had anything. That helps me kind of know what they're probably going to be getting. And if I need to protect myself, which is kind of here in the bottom, you see the part that says isolation for MRSA, C. diff, VRE, or just a line you can write down what they're positive for if it's been confirmed, so you can wear proper PPE. And then you see the part that says protocols. Some hospitals are more specific about those. I would just mark potassium, magnesium, phos if they're in replacement and which one. And then what they're getting for GI prophylaxis, what they're getting for clot preventing, and also core measures. And on the bottom here, you see the hours, 7, 8, 9, 10, 11, 12, or night shift, 1920, 2100. That's mainly for eyes and nose. If you have like some drains that you're emptying, you can jot down, or like urine if you empty in the Foley, if they peed in the urinal. And there's a little small square that's empty. I would write anything that's like pending, if patient's going somewhere, if they have surgery scheduled, or any kind of intervention that's planned, kind of like future, what the plan is, what the goal is, stuff like that. And then on the other side of the sheet, I would usually write what meds are due and when, any kind of notes, anything I want to ask doctors for. If I contacted doctor, we usually write the time I called them or reached out to them, and the reason and the name. That way I can chart on it, and that way it doesn't get lost that I did do an intervention of notifying the MD. So this is it. Thank you again for your time. I hope you enjoyed this video. And if you did, please subscribe, give this video a thumbs up, and I hope I'll see you next time. Have a good day. Bye.